Good evening, everyone. Welcome to tonight's Men's Health webinar. Tonight, we have the privilege of hearing from Dr. Ryan Dornbier. He's a men's health specialist, a urologist. He's located right in central Iowa in Des Moines with the Urology Center of Iowa. He's going to be talking to us tonight about the signs, symptoms, and treatment options for erectile dysfunction and male stress urinary incontinence. We encourage you to ask questions during this presentation. To do that, you can move your mouse on your laptop, desktop, or tap the screen of your mobile device. You're going to see a toolbar pop up in Zoom. One of those tools says chat. So you click on that, type your question in, hit submit, and at the conclusion of his presentation, we will answer those questions. Now, without further delay, I'd like to introduce Dr. Ryan Dornbier.
Thanks, Mike. Appreciate the introduction. Hello, everyone. Thanks for joining us tonight for our webinar about men's health topics. Hopefully everyone survived the cold and blustery weather today in central Iowa. But thank you again for joining us. Just to start, a lot of the information I'm going to talk about today is on this website here. Give anyone a second to scan the QR code if you feel necessary, but it's a very easy website to remember. It's www.edcure.com. We'll have a lot of good videos and information there. As mentioned, my name is Ryan Dornbier. I'm one of the urologists at the Urology Center of Iowa. I did complete my training about 5 years ago now, and I'm a fellowship trained men's health and reconstructive urologist. Most of my training was in Chicago, but been working here in Des Moines for going on 5 years now. So erectile dysfunction. So what is erectile dysfunction? It's typically defined as the inability to achieve or maintain an erection for satisfactory sexual performance. It's a very common condition, and in my opinion, definitely underreported. It occurs at about 1 in 5 men over the age of 20, and about half of men over the age of 40. And you can kind of continue to extrapolate that to a point where you get into your 70s and 80s, somewhere between 80 and 90% of men are going to have some form of erectile dysfunction. So what's important to know about erectile function, erectile dysfunction, is that there is also obviously erectile function. What happens is we're either stimulated or aroused. There's a relaxation of smooth muscle that allows blood flow into the penis, and then that ultimately results in some trapping of the blood inside the penis, which results in stiffening and firmness. Once activity is completed, that blood is then allowed to flow out to allow for detumescence of the penis. So basically, erectile dysfunction then is the disruption of one of those processes, either the arousal process or the blood flow in process, or very commonly the blood trapping process. There's no real single cause of erectile dysfunction, but we do kind of break it up into two different components, what we would consider psychological erectile dysfunction, but more commonly, what is considered organic erectile dysfunction, which has multiple risk factors, many of which are common diseases in the United States that result in vascular disease or issues with neuropathy. And we'll go over a lot of those conditions today, but you can see the breakdown there in the pie graph in terms of about 40% of men are vascular related erectile dysfunction, or about 30% are related to diabetes, and then some smaller components that can lead to erectile dysfunction. I kind of touched on it briefly, but a certain component of erectile dysfunction is related to psychological stressors. Sometimes this can be very similarly related to performance anxiety. It's also associated with other common conditions like depression, decreased quality of life, and anxiety. A lot of times I relate it to the fact that when you do start to experience some form of erectile dysfunction, you start to have concerns about your overall performance, and that leads to worsened erectile dysfunction. Basically, your sympathetic nervous system kind of gets overstimulated, and therefore you can't get an erection. I equate it to that. You have that anxiety or fight or flight response, and when we evolved, it was not convenient to have an erection when you were running from a bear. So there are a lot of different ways to treat this, but a lot of what we'll be talking about will be more related to organic erectile dysfunction. So One of the most common conditions associated with erectile dysfunction is diabetes. About half of men with diabetes will have some sort of sexual disturbances. The erectile dysfunction related to diabetes comes from both poor blood inflow, poor blood trapping, and neurologic decreases that are associated with diabetes. This means that they're often much more difficult to treat in patients who have diabetes and erectile dysfunction together. Kind of like I just discussed, part of the issue with diabetes is that your increased blood sugars leads to damage to the vasculature, which ultimately makes it very difficult for those arteries to dilate and allow for increased blood flow in. And then also the veins are slightly less compressible, and therefore it's very difficult to trap the blood inside the penis. But in addition to that, it's hard to stimulate to develop erection because the nerve fibers that help to stimulate erectile response are often damaged related to diabetes as well. Factors that may increase ED in men with diabetes: always advancing age. Age and erectile dysfunction go hand in hand. The length of time you have had diabetes, overall blood sugar control, as well as concurrent heart disease or diuretic use. And with that vein, or with that side of things, heart disease is also associated with erectile dysfunction in many circumstances. Symptoms of heart disease are often preceded by erectile dysfunction, and that it could be the first presenting sign that there might be something going on, not only in the penis, but also in the heart. Erectile dysfunction can also correlate with the severity of heart disease, and men who have had prior heart attacks or strokes or some sort of vascular dysfunction can often lead to erectile dysfunction. And the reason for that's fairly simple, because when you look at your overall blood vessel diameter, the blood vessels in the penis are fairly small and smaller than the blood vessels that are in the heart. And so if you think about vascular disease and narrowing of blood vessels, the vessels that are going to become occluded first are those smaller vessels. So typically the penile artery will start to occlude, and then a few years later you might have your first heart attack because your arterial vessels to your heart are occluding. So what are things that you can reduce your risk of heart disease and also lower your risk of erectile dysfunction? A lot of erectile dysfunction specialists will tell you that erectile health is cardiac health. So things that you can do: eat well, try to avoid a Western diet, fresh fruits, vegetables, low fats, low red meat content, increase your physical activity, try and lose weight, stop smoking if you're a smoker, avoid alcohol if you are a heavy drinker, try and reduce your stress levels. If you have diabetes, control your sugars. A much more what would be considered endocrine dysfunction would be low testosterone associated with erectile dysfunction. And this comes on a little bit differently than erectile dysfunction in general. Typically, you might still have okay erectile response, but maybe your libido is decreased, or you're too tired in the evening or in the early afternoon to engage in sexual activity. But it can also have a component of effect on the vasculature directly. So low testosterone is more likely in, again, older patients, patients with obesity or overweight, patients with diabetes, patients with sleep apnea or other chronic medical conditions like kidney dysfunction and liver dysfunction, or men with HIV and AIDS. Some symptoms of low T, touched on them a little bit, but decreased libido or reduced sex drive, loss of pubic hair, shrinking of the testicles. You start to develop hot flashes, signs and symptoms of depression, increasing body weight, potentially some breast development, decreasing muscle mass, and decreasing endurance or ability to recover after long exercises. If those things are happening, please give us a call, but they can also be associated with your erectile dysfunction. So ways that we can replace your testosterone: becoming more familiar with these as it's being talked about a lot more, I think among men, and that there are injections, there are patches, there are oral medications, and gels. One of the biggest reasons for kind of acute onset erectile dysfunction is treatment of prostate cancer. So men who have had prostate cancer and had it treated are typically well aware of this, but one of the treatment options is prostate removal, or what's called a prostatectomy. And what happens is we take the prostate, remove it from in between the bladder and the urethra, and then reattach the urethra and the bladder back together. But what this can do is damage the muscles, damage the nerve fibers, and damage the vasculature that supplies blood supply to the penis, which can ultimately leave a man with permanent erectile dysfunction after surgery. Newer developments in surgery or newer techniques and the use of robotic technology have improved erectile function after prostate surgery. Things like what's called a nerve-sparing prostatectomy, which most urologists are doing at this point. Especially newly trained urologists, have improved erectile dysfunction, but there's still a very significant degree of erectile dysfunction after prostatectomy. About 50% of men will have erectile dysfunction that is complete, and another 25% will have erectile function decline. And another possible cause is treatment with radiation for prostate cancer. I usually say again that after you receive radiation, you're going to experience damage to those nerves and that blood supply to the prostate, which can affect overall erectile function. And about 50% of men after radiation treatment are going to have complete erectile dysfunction as well. Very similar numbers to surgery. Another condition associated with erectile dysfunction is what's considered Peyronie's disease. This too is getting much more attention, and I'm seeing many more men present with penile curvature, partly related to some advertising, but also men are talking about it a lot more. So what is Peyronie's disease? It's the development of scar tissue in the erectile body of the penis that leads to curvature in the direction of the scar tissue. It's a benign lesion, it's not cancerous, but it can sometimes hurt or be firm, especially when the penis first starts to curve, but then will stabilize with time. The issue with that plaque is that ultimately it can lead to poor blood flow through the scar tissue, which then leads to sometimes engorgement before the scar tissue, and then maybe erectile dysfunction beyond the scar tissue. So treatment for Peyronie's disease outside of erectile dysfunction, there are medications, but we don't, mainly anti-inflammatories to improve any pain you might be having, surgery to remove the scar tissue, but then also penile prosthetic surgery, which we'll talk about more in a minute. We're going to skip this real quick, but just go to the treatments for erectile dysfunction. Who treats erectile dysfunction? Well, a lot of physicians now treat erectile dysfunction. It might be your general practitioner, your family doctor, definitely urologists, but then also prosthetic urologists or men's health specialists who have specialized inside the field of urology. What are the treatment options? This is just a brief overview. There's oral medications, there's vacuum devices, there's injections into the penis, and there's also penile implants. And we'll go into each one of those a little bit more individually, but I always talk fairly significantly about individuals improving overall quality of life. This goes back to that slide where we talked about heart disease, things that you can do to improve your erections without taking any medications. One of those is lifestyle modifications, quitting smoking, losing weight, increasing physical activity, but also psychosexual therapy if you believe that you're experiencing psychogenic erectile dysfunction. Attempts to decrease anxiety, especially anxiety around performance and anxiety around sexual activity. Oral medications, these are called PDE5 inhibitors, commonly Viagra, Cialis, Levitra. There are a number of different medications on the market. The goal of these is to take the medication and helps improve blood flow to the penis. The Overall, if you took all comers with erectile dysfunction, about 60% of men are going to respond to medications. The difficulty with them is, one, you have to time things out. Some men get headaches, facial flushing afterwards. Some men experience hangovers, heartburn. Sometimes the side effects are bad enough that you just don't want to take them, and most men, or some men, will stop taking them related to the side effect profile. But they do have a very good effect, and they're very commonly used, and most men by this point have tried them by the time they get to my office. Another thing that we see used is what's called a vacuum erectile device. I use these in very specific circumstances, specifically post prostate removal, because it does help with penile recovery after prostate surgery. But most men, in terms of general use, tend to find them cumbersome and difficult to use, and not really anything that is comfortable, because in order to get the erection, you have to put the vacuum around, pull blood into the penis by creating a vacuum, and then put a ring around the base of the penis, which can cause numbness, bruising, discomfort. If you ever put a rubber band around your finger, you know how quickly that can happen. So typically men will stop using them fairly quickly after initiating. A very commonly used medication after you've kind of failed oral medications, or even before you failed oral medications, is what's called intracavernosal injection. This is a medication that you inject yourself about 10 to 15 minutes before you want to get an erection. It's usually a very small needle. If we talk about, again, all comers with erectile dysfunction, about 90% of men will respond. And usually have a pretty good response, but there are some drawbacks. One is the pain and discomfort at the injection site, some bruising. You can develop scar tissue and develop Peyronie's disease related to use of injections. And sometimes it is fairly inconvenient and can have a substantial cost. Most patients typically withdraw after 3 to 4 years of using injections, just because it becomes too cumbersome and almost painful, or they develop that scar tissue issue. Kind of the last, and what I call the kind of, for men either who have failed multiple other trials of things, or have end-stage erectile dysfunction, are no longer responsive to medications and injections, is what's called the penile implant. Typically, I will use an inflatable penile prosthesis. This is a device that is implanted into the penis with the intention of giving you an erection on demand. A pump is placed within the scrotum that is manipulated to bring fluid into these cylinders inside the penis that ultimately leads to an erection that's rigid enough for sexual penetration. Biggest drawbacks is it is a surgical procedure that requires it to be placed. It's a mechanical device, so sometimes they do fail, and rare things that happen like erosions or infections, but those are pretty uncommon. There are multiple of these devices on the market. Here are a few of them. The one that I most commonly use is called the AMS 700. Again, it is an inflatable device where the pump goes within the scrotum in between the testicles, and the cylinders go within the penis. It provides very adequate rigidity, and these devices are regularly placed in many markets around the country. Just a overview of how it works. So you pump the device within the scrotum, and that brings fluid from this reservoir up by the bladder down into the cylinders in the penis. Once it's fully erect, or you're done using it, you hit a button, and that reverses the flow, and then goes back to a flaccid state. There we go. These are very commonly performed, much more so than I think many patients realize, especially when we begin talking about them. What I tell most of my patients is that it's an outpatient procedure. Sometimes I'll have you come back to the office the next day to remove a drain, and then I have you come back about 2 weeks later to check the incision in that time period. I typically say take it kind of easy. Don't do any strenuous activity or aggressive exercising. Try and ice things as much as you can. That will help the swelling and any discomfort you have post-surgery. And then usually by that 3 to 4 week mark, I'm activating the device and allowing you to start using it for sexual activity. Typically they're covered. Most commercial insurers will cover the device. Medicare will definitely cover the device. Has had a national policy for erectile dysfunction and penile implants since their development. But there are options for help with coverage if your commercial provider does not provide coverage for them. Many patients have a high degree of satisfaction once they've recovered from the surgical aspect of things. Basically, they tend to be more convenient and have a higher reliability than medications or injections. Again, very high satisfaction rates, tend to be covered by insurance, very reliable and durable. Resurgical rates for these are only about 90 or 10% after 10 years, so very long durability. They have a very natural appearance and will not disrupt your ability to ejaculate or orgasm. Possible risks, again, it's a surgical procedure, so there's recovery to that. It's a mechanical device, so sometimes they do break down, requiring additional procedures. Infection risk is about 1%, and sometimes the infection becomes bad enough where I do need to remove the device. Things like unintended inflation of the device are less common with newer models, but it has been reported, which can lead to some soreness or tenderness. Again, you can go to the website edcure.com for a lot more information than I've discussed, and there's a lot of interactive tutorials and videos and descriptions of medications. But the journey for erectile dysfunction can be long, but just remember that it's very common and you are not alone. So please talk to someone if you're experiencing this. We're going to transition now to leakage of urine, or what's called urinary incontinence. Again, a website called Fix Continence or fixincontinence.com. Please visit that site if you're experiencing, again, very high quality videos and questions and answers. So what is stress urinary incontinence? It is stress incontinence happens when movement or activity puts pressure on the bladder, causing leakage of urine. These movements can include coughing, laughing, sneezing, running, lifting, or just general walking around. It's fairly common after prostate removal or prostate surgery. You can see the statistics there. About 17,000 men will develop stress urinary incontinence, which is bothersome annually. So the urinary process anatomy is important. The bladder sits here and is designed to store urine. Urine exits through the urethra, and here is your muscular sphincter, which is designed to control the release of urine. If the sphincter is disrupted, or in some cases the prostate is disrupted, there is less of a barrier of resistance that keeps urine in, and therefore pressures to the bladder can lead to leakage. So what are some things that can cause stress urinary incontinence? The most common is by far prostate removal or prostatectomy for cancer issues, but also radiation or anything that can damage the external sphincter, such as procedures for benign prostatic issues, pelvic surgeries, neurologic conditions, or prior urethral surgeries. In my opinion, this is probably the worst thing about prostate cancer and prostate cancer recovery, because men who do experience urinary leakage after prostatectomy can have a very significant quality of life change. It can lead to symptoms of depression, social isolation, anxiety, and often leads to men kind of becoming more reclusive because they're worried Do I smell like urine? Do I have enough pads? Is there a bathroom close enough if things were to get urgent? Again, we do a very high number of prostatectomies. Prostate cancer is the most common cancer diagnosed in men in the United States. Not all need treatment, but many do. After prostate removal, I usually quote about 10% will have bothersome leakage about a year after treatment. But that is more common in older men. Men in their 50s, it's probably closer to 5%, but men in their 70s, it's probably closer to 20%. Again, the same kind of schematic that we saw earlier. Prostate is removed, urethra and bladder are reattached. When you disrupt that mechanism, a lot of men do rely on their prostate fairly heavily to maintain their urinary continence. So when that is removed, it can lead to leakage. So again, we go to treatment options. There are a lot of things that you can do to try and cope with these things. Many patients have already started to change their behaviors, know where bathrooms are, plan bathroom breaks, or drinking less fluid, trying to prevent things, especially when they know they're going to be out of the house. Things like physical therapy have been proven to help, especially if you have a very minor degree of urinary leakage. Things like Kegel exercises can help, but a lot of men are already using coping mechanisms. They're either going through pads, wearing Depends or diapers, or using a condom catheter or penile clamp, what's called a Cunningham clamp, to try and prevent the leakage, or at least deal with it as it's happening. When it comes to a little bit more active treatment, really the best options for these type of things are surgical. There's essentially two surgical options. The first I'll talk about is what's called the male urethral sling. This is to treat men who maybe have leakage that is a pad or so a day. They feel leakage, but necessarily can't demonstrate it on physical exam. It's a device that is used to support the urethra and provide additional resistance to the flow of urine out. And we should have a picture perfect. So it kind of creates a hammock around the base of the urethra and uses the pubic bone as a support to anchor itself. This is placed via an incision behind the scrotum. I place the sling and then pull up to create that tension and that increased resistance to urinary flow. In appropriately selected men, meaning those that have no history of radiation and only mild to moderate leakage, it's a very effective form of treatment with a decrease in pad usage rate, and most men are almost completely dry. A second option, what was probably more aggressive option, but probably the more gold standard of treatment, is what's called an artificial urinary sphincter. So this is for men with any degree of urinary leakage after prostate removal or prostate surgery. It is a device that is placed via two incisions, one behind the scrotum and one in the abdomen, that creates a cuff is placed around the urethra to provide resistance to the flow of urine out. Definitely for men with moderate to severe urinary leakage, but also men with mild as well. And again, this is more of a schematic picture. The device is placed around, or the cuff is placed around the urethra to provide compression. A small balloon is placed up near the bladder, and then a pump is placed in the scrotum next to the testicles, that when you do have the desire to void, you squeeze the pump. That relaxes the cuff and allows you to urinate for about 60 seconds. Again, another video. You can see all the device components are maintained internally. The cuff, which is placed via the incision behind the scrotum, is wrapped around the urethra. The pump in the scrotum is then pumped, which transmits fluid away, relaxes the cuff, and then automatically the fluid will be retransmitted back to the cuff after about 60 seconds to provide more compression to the urethra. This is, again, an outpatient procedure, two small incisions, one behind the scrotum and one up near the bladder. You'll go home with a catheter and then remove that the next day. Um, Again, a period of decreased activity, maybe some icing. Um, and then I have you come back to see me in the office, usually about 6 weeks later, to activate the device, which means you will still leak for the 6 weeks until the device is activated. This is because you need to kind of wait for the inflammation to go down so the device can be manipulated before we can get it cycling. Very high satisfaction rates. Decrease in pad usage tends to be 1 to no pads a day, which is a significant improvement in most men who are going through 5 or 6 or 7 pads a day. Many patients are very satisfied. And you can see the numbers there. Many would recommend it to a friend, and most patients have not required any sort of additional procedures after the operation. Again, coverage should not be an issue, especially if it's related to your prostate cancer recovery. I don't think I have had much pushback on any of these devices once I indicate that a patient requires one. Just a quick testimonial there from Herschel. Goal is to achieve better bladder control, to be able to urinate when you want to and not leak, decrease pad usage, and restore normalcy and avoid those social concerns with renewed confidence. Possible risks, again, surgical procedures are always associated with some degree of risk. For the sling, it might not improve your leakage as much as you desire. There are occasional instances of urinary retention in which a catheter needs to be replaced, postoperative pain and irritation at the incision sites. The artificial sphincter, again, mechanical devices sometimes malfunction and require revisions. Issues with erosion of the cuff into the urethra, which would require the device to be removed. Again, urinary retention, usually just briefly in the postoperative period, and then infections, again, which would require the device to be removed. So just in quick summary, incontinence after prostate removal is very common. There are a multitude of treatment options beyond just conservative options. The sling and the artificial urinary sphincter are great long-term options, so please give us a call if you're experiencing one of these things. I believe that is all.
Thank you, Dr. Dornbier. We do have several
It looks
questions.
like there are a few in the chat.
So first question, can ACE inhibitors cause erectile dysfunction?
ACE inhibitors. They have been associated with some mild degree of erectile dysfunction. It's not the most common blood pressure medication to result in erectile dysfunction. More commonly, those would be beta blockers or calcium channel blockers like amlodipine. But if it's a new medication that you just started and all of a sudden you feel like you're experiencing worse erectile function, then it could absolutely be the ACE inhibitor.
Thank you for that response. Now, the next question, this person says, I've had 2 TERPs and Viagra doesn't work for me. So what's your next step after that? So Viagra's not working. Where do you go for this patient?
Yeah, so there's a lot of options, kind of the ones that we discussed. And really it comes down to where you are at in life and where you're at with your erectile dysfunction journey. If you had a TERP and you're 55, we might, and medications aren't working for you anymore, then we might say, maybe you want to do injections for a couple of years and see how it works for you. But if you're maybe an older gentleman and have some associated comorbidities beyond just the BPH, maybe you have some heart-related issues, or you have diabetes, which is well controlled, then I might start talking to you about a penile prosthesis a little bit earlier to say, why don't we just take the next 15 years and not have to worry about all these medications and injections and all that kind of stuff. So it really depends, and it's definitely a conversation where we almost spitball some ideas in terms of what's the next best choice for you.
Thank you. Now, this gentleman says he's had 2 procedures on his prostate, the last being a green light procedure. Says finds himself having constant urination problems. Are there any new procedures that can correct this? So I'm not sure if this is stress, urge, or just a lot of urination.
Yeah, it's tough after a green light. one, I'd want to reassess your prostate. See, is there any more tissue there that needs to be taken out? Is there any degree of obstruction still there? Because we might be dealing with maybe not stress urinary leakage, but urge urinary leakage, meaning you can't get to the bathroom in time, you're peeing frequently, you got to find a bathroom very quickly, which sometimes can be a more bladder-centric process as opposed to being related to the prostate. Things like overactive bladder or certain degrees of neurogenic bladder. So depending on what we find, we might say, well, do you need some medications to help the bladder to stop contracting so aggressively, or potentially maybe even some Botox injections into the bladder. But any urinary leakage we can assess and figure out what's going on and work with you to get it treated.
Thank you. Now, we've got a question about implants. So if somebody does go forward, if they're having incontinence and they get a sling, after they do that, are they able to get IPP or even maybe an AUS?
So if you had a sling and start to experience renewed incontinence, then my typical recommendation would be to proceed with an artificial sphincter. Neither of those would preclude you getting a penile prosthesis, unless there was a certain way that the artificial sphincter was placed. That might preclude that, but for the most part, a general artificial sphincter placement would not preclude you getting a penile prosthesis.
Now, so the question is, when can one start Kegel exercises after PFPT, pelvic floor physical therapy?
Pelvic
Got it.
floor physical therapy.
Yep.
I
After
assume this would be for someone who has
prostate
had
surgery.
their prostate removed.
Yep.
One of the things we're trying to get towards would be to have patients meet with a physical therapist before their prostate removal, so they can learn pelvic floor physical therapy exercises or Kegel exercises before, so that once their catheter is removed, they can start doing the exercises. So there's no point in doing them when the catheter is in after your prostate is removed, but as soon as the catheter comes out, you can start doing those exercises.
Thank you. Next question. Is there low T treatment that is used in conjunction with a penile implant?
Absolutely. We have several patients who, a multitude of patients who either come in and they're first on testosterone replacement therapy, and they start to experience erectile dysfunction, or even after a penile prosthesis is placed, and they start to feel more fatigue or issues with libido. And so we start them after the fact. It doesn't really matter in which order, but there are options out there.
Next question is, what are your thoughts on using a Wisner clamp for a short period of time to treat incontinence?
Yeah, kind of like you mentioned, I wouldn't use it long term. It's again one of those coping mechanisms. Ultimately, they do lead to compression and irritation externally. Sometimes if they're too tight, they can lead to, and placed the same location every time, they can lead to thinning of the urethra or thinning of the erectile bodies of the penis. So if it is something that you decide to use, I say use it for about a month at a time at a certain place on the penis, and then move it either around, so you're not keeping it at the same location all the time. But if they work for you, they work for you, but I think there are some better options.
The question is, how long should either implant last, or how long would you expect either one to last?
So I'll start with the penile prosthesis. What I tend to quote patients is that revisions are not common. There are certain things that would prompt revisions. But if you look at the overall body of literature, replacements because the device is breaking down are rare, only required maybe 10% of the time by 10 years after the initial implant. And then by 15 years, we're closer to maybe 50% of those devices needing replaced. That's fairly historical data at this point, but it's a good reference range. But there are guys who you see walking around who, might have had an implant before I was born. But I've seen guys who have had them in for 20, 25 years and have no issues with them. The artificial sphincter, they're a little bit more of a, I'll say quote unquote fragile device, which is by nature, less fluid in them. And they tend to not break down, but something happens, in a 10-year span where if I say that you have a 20-year life expectancy when I put the device in, I'll say you'll probably need at least one revision.
Thank you for that. This question is, where can I find what type of Kegel exercises? I imagine the question maybe we'll ask is, where can somebody find guidance, assistance, showing them what to
Yeah.
do?
Without giving you our literature right now, we typically do have a packet of information about Kegel exercises that we hand to patients who are immediately post prostatectomy. This kind of goes back to the point that, I think we're really trying to move towards, and that's to have you do what's called prehab or pre-prostatectomy physical therapy, kind of get you in tune with your muscles. The physical therapist can teach you how to do the exercises before you have your prostate removed. And then we send you back to physical therapy after your prostatectomy to kind of reestablish those exercises. They're really hard to learn just by watching videos or reading a piece of paper. So I do encourage men to go to physical therapy to learn Kegel exercises.
So the gentleman with who raised his hand, unfortunately, participants are not allowed to speak during the presentation, or that ability is not there. So if you wouldn't mind just typing that question in to the chat, I'd appreciate it. And that's the end of our questions now. So as we wait for more to come in, Dr. Dornbier, where can people, if they want to learn more about you, maybe see you, what's the best way for them to do that?
Sure. So I don't know if it's on this slide, maybe. Oh, it's not, darn. So we are at Urology Center of Iowa. Our website is www.iowauro.com, IOWAURO.com. That'll have all of our clinic information, our locations. I currently am working in Pella, Broadlawns on the east side, and then in our main office in Clive. And I always want to make sure I actually get our number right, because I've told patients wrong before. It is 515. Where is it? 515-400-3550. I always switch the 3 and the 4. So 515-400-3550. And that can help you call to make an appointment.
So 515-40.
400-3550. 515-400-3550.
So that website and that phone number in the chat, and everyone will receive an email tomorrow with that information as well. So we did have more questions come in.
Sure.
So this gentleman says, recently had a slight increase in bladder leakage. My urologist changed my medication from oxybutynin to trospium. So are there medications that will help with incontinence if it's urge as opposed to stress?
Sure. So typically our pathway for men with urge-related incontinence, which is a little bit of one, we have to define your type of incontinence first. Some men have pure stress incontinence, some men have pure urge-related incontinence. A lot of men have mixed. And so one, is your incontinence related to your bladder alone, or is it related to your prostate being obstructive to your bladder? If that's the case, then it might benefit us to treat your prostate as opposed to treating your urgency. When it comes to medications for urge-related incontinence, A lot of times we'll start with anticholinergic medications, which there are a multitude on the market, including oxybutynin and trospium, solifenacin or Vesicare, tolterodine. Those are the top ones on my brain. But then there's a second class of medications, what's called beta-3 agonist therapy, where there are two on the market. One's called Myrbetriq or Mirabegron. The other one's called Gemtesa or Vibegron. Those tend to work pretty well and have fewer side effects. So if we can get them covered, I'll try to start men on those. But then if those don't help and it's purely bladder-related urge incontinence, then we can talk about Botox injections or sacral neuromodulation or PTNS therapy. So there's kind of a gradation of how we progress with that type of leakage.
Yeah, now there's a question about the firmness of a penile implant. How firm do they get?
Firm, kind of short answer, but firm enough for uninhibited sexual penetration. It is I'm not going to say different erection, but it is now a mechanical erection. The only thing I do warn some patients about is that you sometimes do develop a little bit of floppiness to the head of the penis, but the erectile bodies are firm enough to engage in sexual penetration. It's going to feel hard.
And the PSI is, I think, several times greater than that of a basketball inflated.
Yeah, I don't know the exact numbers, Mike. You probably know that more than me.
So it's at least double what a traditional basketball would be. So for those that can gain an erection but can't maintain it for full intercourse, is there pills that are more fast acting that others that can supplement if someone's not able to make it through
Yeah, so
sex?
that's one of those questions where we have to talk about, are you having issues getting blood flow in, or is it blood trapping that's the problem? Blood trapping or erectile dysfunction, we call venous leak, is much more difficult to treat with medications. If we're talking about timeliness and utilization of the medications, I often recommend that men take a daily Cialis or daily tadalafil to kind of keep a kind of baseline level in the bloodstream. And then if you need more to encourage an erection when you want to get one, then you can just take an additional 2 or 3 5-milligram tablets, maximum dose of 20 milligrams, but it just kind of keeps that baseline in your bloodstream and then give yourself a little bit more and it kind of peaks you a little bit faster.
Looks like we got one more question here. So someone with an enlarged prostate is treated with tamsulosin and is also experiencing ED. I'm not sure what. So does that tamsulosin have any effect on erectile dysfunction in addition to the urgency?
Not directly. There is some reports that it can lead to mild declines in erection, but it's not kind of a quote unquote listed side effect. The bigger issue is ejaculatory dysfunction. It relaxes the bladder neck, and so men get retrograde ejaculation, meaning that when they go to orgasm, the ejaculate does not go outwards, it goes back into the bladder, and you pee it out later.
I'm not sure if I captured the full nature. I think there might be a typo in that question, but that looks like our final question for the evening. So at this point, Dr. Dornbier, I'd like to thank you for your time joining us this evening. I know you have so many things going on. It's a wonderful presentation. And I also want to thank everyone who joined us tonight. Do you have any final parting words of wisdom for our audience?
Thanks everyone for joining. I always appreciate giving these talks. I know that men's health topics, erectile dysfunction, urinary leakage, they tend to be very taboo topics. It's important to know that you're not going through it alone. Talk to your significant other, talk to your friends, talk to a urologist, talk to your primary care doctor. Don't sit in silence alone, but also be wary. We know that these things men often suffer alone and will look for avenues that aren't necessarily in your best interest. I have many men who have been roped into some of these men's health clinics that they try and take that suffering and turn it into financial profit. So know that you're not going through this alone. Reach out to our office, reach out to your primary care provider, so that we can get you the help you need.
Thank you again, Dr. Dornbier. Very well said. This concludes tonight's Men's Health webinar. Thank you again all for joining and taking this step forward in your treatment journey. I hope you have a wonderful evening.
Thank you.
So it's a new deck. Obviously, you are a master presenter at this point. Same similar content,
Yep.
but I don't know. You are so good at this. It's but if there's anything that you want to do differently, let me know. Otherwise,
Copy down the people who ask questions, because I was talking to someone there, like, yeah, anyone who asks a question, make sure you send them like a directed email or a reach out call. I know
I
we
will
said
do that.
follow-up emails to everybody, but the people who ask questions, I'm always like, we need to get those guys specifically, and I'll have my office call them.
Yeah, I will take note of everyone that does, and then actually, I can download the chat too and send that.
Sure.
All of the names. And then normal flow, I'll do the introduction. If you don't mind, I'll hit start webinar.
Yep.
A little bit here. Okay, we'll do that now, and then give people a little bit to join. I'll introduce you, and we'll get started.